Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week we had the absolute pleasure to get to know Madhura Balasubramaniam. Madhura is a PhD student in Chennai, India, and she's also the Director of Patient Outreach and Advocacy for the South Asian IBD Alliance. We talked to her about how she got involved with the South Asian IBD Alliance. We talked to her about what it was like to be diagnosed and to get treated for her inflammatory bowel disease and the long process it took. We talked to her about her use of feeding tubes and some of the social stigma that went along with that. We talked to her about the cultural stigma around IBD and IBD therapies and biologics in India, and so much more. This was such a great conversation. Cheers.
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey, guys. This is Alicia. And I think this is a remarkable day for us because this is our first time we are having a guest that is outside the United States. So super, super, super excited because we have so many questions and things to talk about. And we've already started this conversation going down the rabbit hole of like, let's all rail against health insurance. So welcome. Madhura Balasubramanian.
Madhura Balasubramaniam.
Okay. Welcome, Madhura. We are so excited to have you on for many, many reasons, because again, you live in India and you are bringing in a whole different perspective to this. And also you're just a super fascinating person. So welcome to the show.
Yes. Thank you for joining us.
Very first thing we're going to ask you though, which is what are you drinking? And it's very different time zones for us. So what are you drinking?
So since I'm in India and it's 6:30 in the morning here and it's not necessarily cocktail hour, I'm having some warm water and I'm going to follow that up with some South Indian filter coffee. In South India where I'm based, we're very snobbish about our coffee and we make our coffee to its exact particular standards. We have like a homemade filter where, you have the beans ground and you make it by hand and it drips really slowly. And it's a whole mechanism that we go through every day. But I'm starting with warm water just to be a little kinder to the belly for now rather than chugging all the coffee that I really want to chug. What about you guys? What are you drinking?
So first of all, I consider myself kind of to be a little bit of a coffee snob. So I appreciate this amount of detail that you put in your coffee. I do have a regular American traditional coffee pot, but I also have a French press and an espresso machine. So I do love a variety of coffee styles, but it is 8 p.m. where I am, and I'm drinking a lovely glass of sangria.
Oh, nice.
Yes. What are you drinking, Alicia?
I'm drinking a Marionberry bourbon cocktail. So it's very good. It's very pretty. Well, we're so excited to have you on the show. But next question for you is tell us your IBD story. What brought you into our IBD community?
Absolutely. And thank you so much for having me, Alicia and Robin. I'm so excited to be here. I love Bowel Moments. I love some of the podcasts that you've done with my South Asian IBD colleagues as well. It's been wonderful to listen to. So I'm very excited to be here. My IBD story, I'm a Crohn's patient. I was diagnosed in 2019 with Crohn's disease, and I have a bunch of other conditions which I'm going to lay out up front so that I don't forget about them. But I also was recently diagnosed with bile acid diarrhea, bile acid malabsorption, which is a condition that occurs when your body is unable to absorb all of the bile acid that your body produces. So that's also due to the long-standing Crohn's that I've had. And I have a tentative celiac diagnosis from 2005, so it's been a while. I also have a bunch of skin issues, some related to the IBD, systemic allergies, and a couple of things that we're still kind of trying to figure out what's going on. So this is like, very broadly my current laundry list of what's happening with me. But, if I had to put it in a narrative form, I think I've lived with bowel issues for as long as I can remember. And when I was thinking about, how to share my story, it struck me that I actually don't remember long periods where I've just not had diarrhea or where, I've not had bowel issues. So that's how long I've been symptomatic. So all of my childhood is just, periods of diarrhea, vomiting, weight loss, and skin rashes and joint pains and whatnot. And we didn't really know what was going on. So in India, whenever somebody has diarrhea, the first assumption is that this is an infection of some kind because we do have a very large infection burden here. And at the time, we were also, as a country, we were still figuring out a lot of the autoimmune diseases that existed, how to diagnose them better, how to find the tools and the expertise disease that we need to diagnose. So I didn't really have access to that as a child. And so I would just have these periods of diarrhea, go to school in diapers, struggle with incontinence as a child, and get on with it because there were no other options. I'd be put on antibiotics, I'd feel better, and things would move on. When I was 10 years old, I think my mother had had enough of this, and she was just like, this is not sustainable for my child. So I was at 10, I think I was like 20 kilos, which is I think 44, 45 pounds, and I was just 120 centimeters. So my mother was like, this is not normal. Like, this, it's one thing to say your child is thin because she's not eating enough, or, you're not feeding her all of the right things, and this is on you because, you've messed up as a parent in XYZ ways. And she was like, but this is not normal. So she started to push my pediatricians to take this more seriously and to kind of start investigating what was going on. So at 10, I underwent an upper GI endoscopy where they found a lot of disease activity in my duodenum, but they didn't really know what to do with it. And the way they'd taken the biopsies, they couldn't come to a conclusive diagnosis of what was going on. So they were like, maybe this is tropical sprue, which is an infective condition, fairly common in tropical regions like India. They're like, maybe it's celiac. The damage looks quite similar. We don't know what to do. So they treated me with 6 months of antibiotics, and they said, I think we should put you on a gluten-free diet and see how you do. So I went on a gluten-free diet, and this was in 2005. So, and to my knowledge, even today in India, we are very, very far behind in having specialized dietitians who can guide you on how to do a gluten-free diet or how to do some of these medical diets. So this was something that my mother and my pediatrician worked together to figure out for me. And I went on a gluten-free diet, and I started to feel much better as well. So at this point, we were like, okay, maybe perhaps there is a celiac, or like there is some kind of gluten component to this. And that's why I'm responding to it. And that's why, things are slowly improving. But since I never had a definitive diagnosis, it was also a concern every time I'd get sick that there's perhaps more to this picture. And at this point, Crohn's was not in the differential bin. There was no discussion about Crohn's disease or inflammatory bowel disease. At 12, a couple of years later, I underwent another upper GI endoscopy to see if they could come up on a better diagnosis, like a more definitive diagnosis of what was happening. And they found that, chunks of my bowel had healed. So I was told that, we can't see any disease. So we're not sure there was anything here to begin with. And are you sure that this is not something that's in your head? And it wasn't necessarily said to me in that way, but I was 12, and this was my key takeaway from that appointment, that perhaps I didn't have anything, there was nothing wrong, and maybe this was just, something that I was imagining, and that people just lived like this, that people just had diarrhea and dawn, and I was making a big deal. So I also never had anybody in my family who had either celiac or Crohn's or any kind of a chronic bowel condition. So I also didn't know what it is that I was going through, or how to speak about these things, or how to advocate better for myself. And to be fair, my parents didn't know either how to advocate for their child at this point, and this is also when we're still figuring out how to access the internet and how to really, and I don't know, kudos to my mother for having brought it this far and having pushed this hard. But when medical professionals tell you we don't see anything, so there isn't anything there, it starts to weigh on both the parent and the child. And, somewhere it's taken me so many years to really start believing that just because the medical technology or the medical expertise isn't at a place where they're able to figure out what's going on with you doesn't mean that there's nothing wrong with you, or doesn't mean that this is in your head. It just means that technology hasn't necessarily caught up, and it's something that the doctor and the patient have to figure out together. This is not the time to place it on the patient. So, but it's taken me a while to get there. What this entire, engagement did was that I started to minimize my symptoms. So I would again go through these periods of a couple of months where I'd be really sick. I'd bounce back, I'd move on with my life. So I got through high school and university like that. And when I was around 22, 23, I'd started my first job as a field researcher. So I used to work as a research associate, and my responsibility was to go on the field, go to Tibetan refugee communities in different parts of India and work with Tibetans there and build out my research through qualitative interviews. And as I was traveling, I was starting to get sick again. I would have diarrhea and incontinence. And I was like, this is not right. So I started thinking maybe, I'm having gluten somewhere, and, I haven't really kind of figure out what I'm eating, or this is an infection. And it kept going on. And I kept refusing to go to the doctor because I was just like, listen, if they're going to tell me this is, they can't find anything, what's even the point, right? Like, there's no real point here. So at that point, I kept resisting. I was very sick. You could tell my diet was like, the quantity I was eating was coming down very rapidly. The diversity of the foods I was eating was coming down very rapidly as well. I was stopping to eat dairy. I was stopping to eat vegetables. There were a couple of things which I'd cut down because of the symptoms, and I hadn't processed what I was doing. So my supervisor at that time, the amazing person that she is, she was like, okay, you have, vacation days. I need you to go and take care of it. And if you don't take care of it, you're not allowed to come back to work. So just go. Just please go. I can't see you this sick. You really need to get this sorted. So that's really what pushed me to, get my care and to really inquire about what was going on. And this was also at a time when I was getting ready to apply for my PhD to grad schools abroad. So I was like, nah, I'll wait. It's okay. This is fine. This is just diarrhea. She was like, no, I'm not doing this. You have to go. I can't have this be a big issue and, have you not knowing what's going on. And then, I don't know, get sick in grad school. This is a really bad idea. You need to go. So I went to a doctor again. And so someone who was also involved in my care when I was younger. So there was that relationship of, okay, maybe, he'll figure out what's going on this time around. And he ran a bunch of tests. And this was the first time a colonoscopy was offered to me. And this was also the first time a fecal calprotectin test was offered to me. And we found that the calprotectin was elevated, and the colonoscopy found IBD and, found a lot of active disease in my ileum, but also in some parts of my colon. And yeah, so that was my diagnosis kind of journey. And it's been a long while to get there. It was also a very long time to get onto the right medication because I was placed on mesalamines. And I think there was a hilarious exchange on Twitter about just how useless mesalamines are for treating Crohn's. But it is the mainstay of treatment, especially for patients in India. For many of us, we are placed on mesalamine as our first-line therapy for Crohn's. And well, it was completely useless, as the Twitter memes have proven. And I had to keep switching doctors and keep advocating for myself to get into better care. So when I met my current GI, who I think is maybe the fourth or the fifth doctor that I've met, I went into his consult room and I was 34 kilos, which I think is 75 pounds maybe. And I was 24 at this time. And I was really sick. I looked emaciated and I had a lot of skin manifestations from my Crohn's. So I'd had a skin biopsy to figure out what was going on. And the biopsy site had opened up. So there was like a massive oozing wound on my shin. And I remember him telling me like a year later that, Madhura, when you walked in, I thought you were 12 years old. I looked at your prescription and I found out you were 24. And I was so horrified. And I was just like, I don't know how this person has been getting along like this. This is not done. So what he did was to say, okay, let's get your nutrition fixed, because I was severely malnourished because of so much active disease that had gone untreated for so long. So he suggested giving me a feeding tube, a PEG feeding tube. A PEG is a percutaneous and endoscopic gastrostomy. So they go in via endoscopy and they put in a tube through your belly. So you feed formula using a drip bag and you feed it into your stomach through the tube. And the goal is to increase your calorie intake, but also improve tolerance to formulas, because it's very hard to drink that kind of quantity orally. When we drink orally, we tend to drink very fast as well, and it's very hard to manage that. So a feeding tube of any kind really can be used very effectively to manage malnutrition, can be used very effectively also to deliver exclusive enteral nutrition, which is a therapeutic option really, which is used as a first-line therapy in pediatric IBD, especially pediatric Crohn's, but adults also benefit from EEN. So I was placed on enteral nutrition. I did partial enteral nutrition at that time, and the goal was to get my weight up, but also to help me kind of bridge between the mesalamines to more effective therapies like a biologic or like, an immunomodulator. And it would then take me another year to really accept that I needed a biologic because of all of the cultural stigma around IBD in my South Asian community, but also all of the stigma around IBD therapies in our community. And I'm really grateful to my GI for having worked with me through all of this and for having convinced me that this is not all in my head and I'm not making up my symptoms. I'm really sick and I need to get the help that I need. but also B, that I deserve quality of life, that I deserve to live better than what I was, currently experiencing. I remember him calling me and being like, Madhura, I'm seeing, a couple of centimeters of disease. It's not a lot, but your current medication is not controlling it. Can we talk about what do we want to do next? Because you're young, you need to move on with your life. You can't be living like this. And I think that was very revelatory to me as well, because I was just like, okay, thank you for acknowledging that I don't deserve to live like this. And it kind of started helping me see things differently as well. And I think, we got a lot of comments about the feeding tube, both him as a physician and me as a patient, and my mother as my caregiver, about the fact that we were crazy. But I think my feeding tube really changed my life, and it gave me control over my disease once again. But it also gave me control over decision making, because I was like, if I can agree to a feeding tube, I don't see why anybody in my community has any decision making powers over my care. So those were the aspects of my journey that I found particularly empowering, and that have led me to also do the kind of advocacy work that I want to do today.
Wow. I mean, I wish this was a video podcast, because you would have seen the number of times Robin and I were reacting to your story.
Oh.
I'm so heartbroken by the fact that they treated your mom and you in this, that just is really hard to hear, but not uncommon, unfortunately.
Yeah.
But there's this, like, it's in your head. But what 12-year-old is like, I want to have incontinence and puke? Like, I'm sorry, I don't know a lot of 12-year-olds that are using that as a way to, like, get attention or something. That makes me mad.
I'm sure there are more exciting ways to get attention than puke your guts, because who's seeing you puke your guts as well, right?
Certainly, yes, more exciting and certainly probably effective, I would have as well. But
yeah.
If you don't mind, let's stick with feeding tubes for a little while. So, because I am curious, you said that people were reacting to it. Is there a reason that they did a PEG tube versus the nasogastro tube? Because I, have seen people using the nasogastro tube, which of course is on your face a lot of times. And so it is a little more obvious. I'm curious why they went with the PEG tube versus the nasogastro. And then were you using the feeding, like, did you have a pack feeding tube or whatever that you were using during the day? Is that how people saw it? Like, how did they know you were using this?
Okay, so I've had both. I've had an NJ much later because I had bowel obstructions and I needed something to kind of open that up. So the reason we decided to go for a PEG with versus an NG is that we were discussing this as well. And the way my doctor saw it, he saw me needing this for at least 6 months to a year, because I was really, really sick and really underweight. So I was at 34 kilos. I'm not a very tall person. I'm about 5 feet tall, but 34 kilos is still ridiculously underweight. So he wanted me up to at least 44, 45 kilos and to be able to maintain my weight there. With the NG, you have to keep changing the tube every 8 weeks to 12 weeks. You have to kind of change the tube, alternate the nostrils, because otherwise you kind of risk a lot of injury and scarring in one nostril. So with the PEG, you don't necessarily have to keep changing the stoma site. So once it's been sited, you can change the tube every 6 months to a year as needed when the tube wears out, but it doesn't necessarily require a complete resiting. So that was really my logic for agreeing to a PEG, because I was like, if you're going to put it in my nose and you're going to have to take it out every 8 to 12 weeks and you want me to keep it for 6 months to a year, this doesn't make much sense to me. So that's the reason we decided to go with a PEG. A PEG is a lot less visible. You can have it hidden under your clothes. But the one that I had, I didn't have a button. I had a dangling tube. So I remember waking up to like a really long tube running down my clothes. And I'm like, I don't need gastroenterologists anymore. I think I need a plumber. I'm going to call a plumber. I was totally out of it. And my doctor doesn't let me live it down. And all of this was happening around the pandemic as well. So there wasn't necessarily a lot of exposure that my extended family or my social circles had to the feeding tube beyond what we were telling them. But there was a lot of resistance initially from my family about it. So my mother was convinced, because she came with me to the appointment, and my doctor explained what is also the research behind enteral nutrition and how it works, but also the fact that I absolutely really needed it, and oral enteral nutrition wasn't cutting it at that point. So she was convinced, but my family wasn't. They were like, why do you need a feeding tube? A feeding tube is a last resort measure. Like, this is something we give to terminally ill people, or this is something we give to really old people. You're in your 20s, why do you need a feeding tube? Why can't you get a second opinion? Your doctor doesn't seem to be right? Why can't you go to alternative therapies? Why can't you seek Ayurveda or homeopathy or naturopathy, whatever? And, they're offering you a cure. This is a diet disease, right? Like IBD in the South Asian community, unfortunately, the community belief is that this is a diet disease or it's a lifestyle disease, and you've done something to get this disease. So it's on the patient to figure out what it is that they did wrong and to fix it, right? So because of that, they were like, why would you agree to a feeding tube? That's bonkers, right? So after all of this conversation happened, we just decided, well, I'm just going to go admit myself. My mother and I went and admitted me in the hospital, and I had to stay overnight a couple of days so that they could kind of tighten my feet. And we didn't tell anybody till after the tube was placed, because what can they do, right? They're not going to be like, you can't remove the tube after it's placed, so screw it. But that is the kind of pushback. And what's sad to me is the kind of pushback we also got from healthcare professionals, because there were other doctors in the team who thought this was not a great idea. My GI really had to convince them. I had nurses walk in when I was getting the feeding tube being like, assuming that maybe I had cancer, or assuming I was terminally ill, or, that there was something so wrong that somebody so young needed a feeding tube. And, they would treat me like this is a last resort measure, right? Like this is not something that's a normal part of how we manage some of these chronic digestive conditions. So there is that aspect of living with a feeding tube. The kind of pushback from healthcare professionals and from, other members of my own community for something that was really transforming my life. Like, it changed my life. I was so, I didn't know what it meant to live without being malnourished. So, I don't know if you guys have experienced this, but when I wore glasses for the first time, I could suddenly see the world clearly, and I could see objects having outlines. So that's how I felt about my feeding tube. I'm like, this is what it feels to be well nourished and to get the nutrients that you needed. And it blew my mind that people thought that this was something that needed to be so stigmatized, when in reality it's saving so many people's lives, right? So I started sharing about it, I posted about it, and my mother got a lot of nonsense for that as well. Because again, in the South Asian community, it's never the individual making a decision, right? So it's believed that it's the family that's made the decision. So people were telling my mother, what's wrong with you? Why would you allow your daughter to make this decision? Or why would you make this decision for your daughter? And my mother's just like, have you met my daughter? I don't tell her what to do. But it's really sad that this is the, kind of myths and kind of stigma and misinformation that we have around feeding tubes. And I'm given to understand that it's the same in the US. It's the same across board, where feeding tubes are just not considered as a therapeutic option, which makes me really sad in many ways. But it also makes me really angry, because I think these are things that we need to see change around life-saving intervention.
I hear that. And as a patient, I feel for you, but as a mom, my heart is broken for your mom. I could cry right now for everything that your mom went through when she was just trying to do her best to keep you alive and safe and healthy. It's not the same situation, but my youngest daughter, who's been on the show, has psoriasis, and you can see that. It is obvious on the skin. And when she was a small child, she was wearing jeans and long sleeve shirts in the middle of summer and not putting on a bathing suit, and because it was all over her body. And I got the opposite of, why aren't you doing anything for her? And I had taken her to the doctor, and I was in the doctor's office crying to the doctor, telling me you can't do anything. So it's not the exact same scenario, but just it kind of takes me back to that feeling of helplessness. And I'm sure that your mom felt so helpless. It just breaks my heart.
She did. And I'm really so sorry that you went through that, Robin. My heart goes out to my mom too, because, as a person somewhere, you feel still in control of your disease in many ways, right? Even if there is so much family pressure, you can still stand up and say, okay, I'm taking these decisions. I'm done with you all. You're not helping me in any way. These are the decisions I'm making. As a parent, you're also witnessing what your child is going through. You're not sure how to help them. I feel really bad. There have been times, in the middle of very bad bowel obstructions where I'm just screaming at my mother because, she doesn't know how to help me, and I don't know how she can help me either. And I think honestly, I would not have survived this journey without her. I'm so grateful for her, and also for all of the work that she's done to protect me from the other crazy people in my family who think that, sorry to say it like that, but there's so much nonsense about like, why can't you do Ayurveda? Why can't you do homeopathy? Why can't you cure your disease? Why are you eating, food in this particular way? Why aren't you eating food in a particular way? And this is all because you're stressed. Why do you have to do a PhD? Why can't you just, I don't know, cure yourself and be the best version of yourself that you can be? And I'm like, excuse me. Thank you for giving me this unsolicited advice. I'll be sure to let my body know. Please stop trying to kill me. Thank you. That'll be great.
It's also like, excuse me, but what about when I was 10? I was not trying to get a PhD when I was 10.
Know.
So what is your reasoning for this to be happening for all of
So
these
that was
years?
all my mom's fault. So that was all my mom's
sorry,
fault.
I forgot.
So it's all worked out, right?
How could I forget that was all your mom's fault and now it's all your fault?
Now it's all my fault. It's all perfectly worked out in the South Asian community to find ways to blame, you, your mom, your your past life sins. And I know I'm laughing about it, but it is just so tragic in so many ways. And I'm seeing so many people being held back by all of this cultural stigma, all of this belief and this pressure to, comply to these kinds of ways of thinking about yourself, of accepting this blame, of saying, yeah, I'm guilty of the disease that I have, and it's my failure that I need a biologic therapy and I can't cure myself by eating, I don't know, fermented rice or something, right? It's institutionalized in so many ways that rebelling against that it also comes at a very significant cost for many of us. And I don't know, it makes me really angry, but I'm also like, this has to change, right? This cannot be how we get along. And I think what blew my mind was the fact that I wasn't the only one going through this. And when I met Tina and some of the others that we work with, and some of the other patient advocates that we work with, there are two of them in the UK. When the four of us met, I'm like, okay, I'm not alone. These women have gone through the exact same thing that I've gone through. So why are we sitting down and accepting this, right? Why are we accepting being treated like second-class citizens in our own community just because we have a chronic illness and just because it's a digestive condition, right?
Yeah, absolutely. And I think it's so great that you guys have stood up, and it comes at a cost for sure. I would imagine you're getting a lot of pushback from your family that maybe weren't as supportive of going on feeding tubes and things like that. I'm sure they're also not real thrilled with you being so very open with your disease. Can I ask you a couple of questions? So in all of this unsolicited advice that you got, I'm assuming that you did try some of it.
Yeah.
Was there anything that they suggested that did help? What were some of the things that they suggested?
Okay, so I have tried some alternative therapies when I was much younger because I didn't really have the answers or the treatments that I needed from the medical care that I was seeking. So these would be medications or some kinds of supportive therapies, largely medication oriented with Ayurveda, homeopathy. I've tried a bit of Tibetan medicine because that's also where my research interests lie. But I never necessarily saw any benefits from it. I didn't experience any challenges or any side effects, but I never saw any benefits. And I would notice that I was still needing a lot of normal medication to kind of bridge me through some of the symptoms. So I was never particularly inclined towards exploring complementary and alternative therapies. I was diagnosed, and a few months later, it was the pandemic. So there were also a lot of issues in terms of accessing care, which also applied to accessing complementary and alternative medicines. And there was, in India especially, there was such a massive outbreak of misinformation and I don't know, camp cures for corona. I was just like, okay, if this is all like nonsense that's happening on the side, do I really feel comfortable trying something for my IBD? And I wasn't. I was not keen to explore alternative therapies at that point. And I've had this conversation with my medical team many times, and they told me, look, you have so many allergies. We don't know what's in your medication. You're reacting to IBD medication. We don't know what will be there in the complementary and alternative therapies you want to try. Is this a risk that you feel comfortable taking? And I'm like, yeah, that's a fair point. Like, I'm sick enough as it is. I do have lots of allergies. I'm reacting to half the medication you're giving me. So forget it. This is not something I want to explore. So what helped me was my mother saying, listen, my daughter makes her own decisions. Do you want to give me free advice? Feel free to give me advice, but you're not talking to my daughter. And I'm so grateful that she kind of stood in between all of this as a kind of firewall for me, because then I wasn't necessarily feeling that pressure of, okay, fine, let me just explore something. So that was my CAM journey as well. And I'm very lucky that way. I know a lot of people have experienced a lot of pressure to explore cures through CAM. I think the power of CAM lies in the promise of a cure and in the promise of absence of side effects. And in the South Asian community, especially because there's so much trust in CAM, and there's so much medical mistrust, partly because of a colonial experience. We did undergo colonialism for over 200 years. And there is a lot of mistrust around modern medicine because of that. And there is parallelly so much belief in this native, going back to the roots therapies, which I'm not dissing, right? I'm not dissing this as a way of life and as ways of being in touch with your body, which is more holistic than what we imagine in modern medicine. The challenge arises when we compare a medication like an adalimumab, which has, several clinical trials, thousands and thousands of hours of research, of patients who've participated in these trials, of doctors who've been involved in these trials, of researchers who brought this molecule forward. When we hold that medication on par with something that you've gotten from an Ayurvedic doctor or a homeopathic doctor, where you don't know what is the research that's gone behind it. And it is in making that decision, we're making so many comparisons about these two medications as if they were equal, as if the biologic has so many side effects and it's like your life is over if you're on a biologic therapy. I've heard this from patients. I had a patient reach out to me and say, people tell me if you start a biologic therapy, your life is over. You can never come off it again. You'll be forever dependent on this drug. And that's it. You can't have any life and it has so many side effects. Whereas an alternative therapy is like, side effect free, it's all rainbows and unicorns and it's going to cure you. It's going to cure your, future generations. That's the kind of marketing that's also done to us as patients, right? So as a patient at the receiving end, when I'm evaluating, why would I pick a medication, which even my doctors don't suggest as first line therapy in India, versus an alternative therapy that's like, yeah, I'll cure you, no problem. This is not a big deal. So I think that's where it becomes so much more complex, because it's hardly ever about the individual or about the family. There is that larger structural context in which we're making medical decisions. And this is a larger structural context that applies to me sitting here in India today, but it also applies to South Asians in other parts of the world, the US or in the UK, because they're experiencing very similar pressures from their families, from the structural conditions within which they're located, but as with the whole immigrant experience and the kind of racism that they deal with added on as an additional layer as well. So it becomes so much more complex. And as patient advocates, to really push through this and to say, this is not accurate, this is misinformation. A biologic therapy is not going to end your life. A biologic therapy has not ended my life. A biologic therapy gave me my life back. So why aren't we talking about that as a community? To really push through that, then, that's where I think there's also a lot of power in us talking about things and sharing our stories and saying, well, I've been through it, but you don't have to go through it, right? Like, I've delayed a biologic, I've regretted that decision to date. That's the only medical decision I regret. But you don't have to do that. Like, you can learn from my experience, right? And I think that's really what started some of these conversations and why I think it's so important and that we have these conversations. And I'm so grateful to you both, Anisha and Robin, for asking me these questions and for us to talk about these things as well, because we're not going to get anywhere if we keep saying this is, something we shouldn't talk about. Like, let's just brush it under the carpet. Let's just put it back in the closet that it came from and let's just not talk about it, because what will people say? What will people think about you if you talk about alternative therapies in a particular way, if you talk about your tradition in a particular way, if you talk about your family blaming you in a particular way? Well, not talking about it isn't helping. So why not talk about it, right? Like, what do I gain from the silence?
Absolutely. I think that's a really important thing to end on on that comment on is, what do I gain from silence? Nothing. You don't gain. And that's why it's so important to speak out and to ask for what you need and to talk about your good and bad experiences. I mean, that's one of the things that, we talk for a couple of other people that have come on that have, started their own social media channels and things like that to talk about their experiences, is to talk about kind of the good, the bad, and the ugly that went along the way and everything in between. So, because we only hear the worst usually on social media. You mentioned Tina and meeting some other ladies in particular and starting to collectively talk about how this works in different places, the United States, UK, and in India. And then you guys formed IBD DACES, which is sort of patient community organization. And then that then spun up to like a larger organization, SIA, but started out with IBD DACES, and you were involved in that as well. And your role with SIA is as the Director of Patient Outreach and Advocacy. So talk to us about SIA and IBD DACES. How did IBD DACES start exactly? And then how did you see it grow so quickly and then kind of turn into SIA? So give us a little bit of your journey on that.
Sure. So IBD DACES was basically, we started as a Facebook group, right? I found Tina on GI Twitter because, like all good researchers, I spend all of my time on Twitter. I'm like, okay, why don't I Google Crohn's and, India and Crohn's in South Asia? And I'm sure I'll find some people to follow. So I found Tina that way. And then I realized that we were on a couple of Facebook support groups. And a lot of what she was saying made a lot of sense to me in terms of pushing back against the myths in the South Asian community around IBD medication and around ostomies as well. So we connected, and through Tina, I met Sharon and Suraksha, who are two of our two patients in the UK. And the four of us were just like, okay, we've been through a lot with our diseases in different ways, diagnostic delays, being told South Asians can't have this disease, being told IBD is rare in India, and being told an ostomy is the end of your life, or feeding tube is the end of your life, biologic therapies are the devil, whatnot, right? And we were like, okay, this is a common experience, right? And what's common among our journeys is also that we've constantly felt this need to be quiet about it. We've constantly felt like this is a private thing, that only you are suffering. There's nobody else out there who has IBD or who might be going through this. So this is something you have to keep to yourself. And because it involves the bowels, it's so much more taboo to talk about. And I think this is common across multiple cultures. In the South Asian community, it just adds another layer of stigma as well. So we realized that we were all going through that feeling of having to be quiet, having to uphold our family honor, or that by talking about our diseases, we're somehow bringing shame to our families. But also somehow our families are blaming us for having this disease and pushing us to find ways to cure it. So we decided that, if the four of us are experiencing it, it can't be a minority experience. There must be other people who are going through it as well. So we started a Facebook group, like a support group, and we called it IBD DACES. So IBD DACES is literally South Asian IBD. DACES is a word that refers to South Asians as a collective group, and IBD because IBD. So we started it as a Facebook support group, and we had so many patients join us. And one of the things that we've been very clear about from the beginning is that we will only share evidence-based information on our group. And we will break down some of this information. We have the training to do it. Let's break it down so that people can make more informed decisions about their care. Like, for instance, I delayed a biologic because I thought biologics are meant for only very severe disease, that you're not supposed to be on a biologic if you don't have a stricture or a fistula. I didn't know that biologic therapies were used to prevent strictures and fistulae from forming in the first place. So I'm like, if I've made that decision, that's a decision I own today, but it's something that I can help other people avoid. Right? Like, I can provide the information that they need. So it began like that. And we very quickly realized that this is so much bigger than a support group. This is like the kind of work that we're doing needs external recognition as well, in the sense that we need to reach more people externally. People who are joining our support groups are self-selecting to join the group, right? They recognize that they need it. But there are so many people out there who perhaps don't know that such an avenue is even available, that South Asians can even talk about IBD. And we started sharing our stories more publicly through the IBD DACES external platform. We started as a social media platform on Instagram, on Twitter, and Facebook. And as we started sharing, I think it also kind of struck us that if we needed to move the needle forward, it isn't enough for the patients to be speaking about this. We need to bring the provider piece into the picture, because I think there is power, just as there is power in this being a global conversation among patients, not just patients in India or patients in the US or patients in the UK, but all of us together as South Asian IBD patients. I think there's also power in us saying this is not just a patient problem. This is something that providers have to invest in. This is something providers are also concerned about. So that's really how we decided to speak to some South Asian providers both in South Asia, but also of South Asian origin in the US and the UK. And we were like, how can we move the needle of care forward for South Asian IBD patients? And a lot of this credit, to give credit where credit is due, is simply Tina's perseverance and effort in bringing all of us together. Because I'll be honest, right? I was very happy being silent about my disease. Yes, I was starting to feel the pressure of not sharing, and it was really starting to weigh on me. But I never really imagined that I would be advocating. I would have shared on my social media and I would have probably moved on. But I think Tina also kind of encouraged us to find our own voices and to find our own niche within the space and to really share what was going on, but also to push care forward, not just share your story to say, oh my God, all of these traumatic things have happened to me, but to say, I don't want to see these things happen to patients after me, right? And I don't want to see another 10-year-old being delayed for it took me 14 years to get a diagnosis between the first endoscopy and the first colonoscopy. These delays are completely unacceptable today. And this is something I'm recognizing now, having worked with Tina and having found my own voice within the advocacy space. And she also brought all of our providers together to say, guys, we need to do something about it. So the way SAIA is structured today, we have Tina as our president and we have Dr. Deepak Parakal at WashU. He's our vice president. And we've got Neha Shah, who I know you guys have had, and we had an awesome episode with her as well. So Neha Shah is our treasurer and director of operations. And within SAIA, we're structured into multiple committees. So we've got the patient outreach and advocacy committee, we've got a professional development committee, and we've got a research committee. So our goal is to kind of address the need for better care for patients of South Asian origin who have IBD. We decided that we had to tackle this as a multi-pronged approach. So we have to address the patient education and the community disease awareness aspects of this in one way. We had to train our doctors to do better. We need professional development in South Asia, yes, to identify what does chronic diarrhea mean, to make the distinction between an infection and an inflammatory process, to make the right referrals, and within the referrals then for gastroenterologists to start identifying IBD better, to start a more uptake of effective therapies. So biologic therapies till date remain very minimally used in India, and part of it is financial. Yes, there is a huge financial barrier for uptake of biologic therapies, but part of it is also provider training, and this is something that we want to address. And the third and important aspect is we need more research about South Asians with IBD. We really don't know what's going on in South Asia. Why is there so just to kind of put this in context, right? I think there was a study in 2010 which found that I think 1.6 million people in the US had IBD in 2010. And just behind the US at 1.4 million was India. And these are figures from 2010. And this is a massive disease burden. These are only people who have been diagnosed. There might be a 2x or a 3x number like me who hadn't received that diagnosis in 2010, but who nevertheless had this ongoing inflammatory process. So in 2022, when our diagnostic capabilities have improved, when our expertise is improved, when more patients know to seek care, what does this number even look like? And why is it that we don't know anything substantive really about what does the disease look like in South Asians? What are the unique ways in which this disease is presenting in South Asians? There is some ongoing research, some excellent work, but we have miles to go. And we're hoping that SAIA's research will really push us forward in that realm. So I work with the Patient Outreach and Advocacy Committee with Dr. Neil Nandi at UPenn and with Dr. Sunit Bhatia, who's in India. And our goal really is to develop patient education and to help patients feel like, they can make informed decisions, they can feel empowered. So one of the things that we do is to really value patient expertise. We believe that patients who have lived experience with this disease have expertise and deserve to sit on the same table as clinicians and share their experiences and help other patients. So that structure drives a lot of our initiatives within the POA, the Patient Outreach and Advocacy Committee. And we're also very keen to push forward medication access in South Asia. So as you can imagine, with the numbers of diagnosis increasing in South Asia, there is a real push for more effective therapies to be A, available in South Asia, they're not, and B, to be affordable in South Asia, which they are not as well. So the way the Indian healthcare system is structured, for instance, we don't have health insurance. Most of us don't have access to private health insurance. Crohn's disease or inflammatory bowel disease is a permanent exclusion from private health insurance. So we're not able to purchase private health insurance. Those of us that do have access to health insurance in India, insurance insurance only covers overnight hospitalization. So it's not covering your routine testing, your monitoring tests that you need, your colonoscopies, your MRIs, your medication. All of this is bonus out-of-pocket expenses. And the SIA team had a recent publication in gastroenterology and clinical gastroenterology and hepatology, where we kind of mapped what are the different challenges to IBD care in South Asia and how can we think about these challenges as opportunities to push forward patient education, professional development, and research. And one of the things that we documented in that study, and it's one of a kind because this kind of documentation has not been done after biologics were introduced in India. We documented what are the costs of medication, what are the costs of blood work, what's the cost of a colonoscopy, to give a broad overview of what is the out-of-pocket cost a patient is bearing. And the burden is massive. So like if the average income in South Asia is around 33,000 rupees, which I think is around $400, just one dose of a medication like vedolizumab is twice that amount at $77,000. And these are costs patients are bearing out of pocket, right? Like, so for instance, I've been on weekly adalimumab for a year now. This is something I pay out of my pocket every single week. And this is at some level much more so than what anybody can afford, right? Like this is not affordable in a high income country like the US. How is someone in India supposed to afford these medications? So what happens is that then our patients come off these medications because they can't afford it. Our doctors are unable to provide us care that's on par with clinical guidelines across the world. And they're struggling because they don't want to put their patients in financial precarity to manage these medications, right? So we documented that in our paper, and we found that just the pricing of our testing, the pricing of our MRIs, the pricing of our biologic therapies, this is something that's putting our patients at financial toxic risk just to be well. So why is an Indian IBD patient going broke just to be well? Like this is unacceptable. And I think it is so important that we document all of this because you cannot start conversations with payers, you cannot start conversations with governments, but you also cannot start conversations with other patients unless we have this documented to say this is unacceptable. So this is something that we've done through SIA and something that I'm very excited that I had a chance to be a part of because I'm just like, this is my life, right? Like we're talking about my life and the life of people like me. And we have to change this one way or the other. So within SIA, as an organization as a whole, we're very committed to pushing forward medication access, to saying how can we make quality IBD care more accessible to all of our patients, because every IBD patient, regardless of where they live in the globe, deserves the quality of healthcare that can be offered to them. And they deserve to have high quality of life. They do not deserve to be steroid dependent. They do not deserve to suffer from refractory disease. They do not deserve to go through surgery after surgery. And they certainly do not deserve to lose their jobs, their families, friends, and live in the kind of isolation that some of us have experienced. So this is a lot of what drives SIA. And I am very proud to say that, I think we're the first patient and clinician-led organization in the IBD space. And every day that I am on SIA initiatives where I'm talking to these doctors and I feel like my voice is heard, I feel so empowered because I'm like, if I as a patient, right, and who am I? I live in one part of India, right? Like I live in one city in India. India is a massive country. If I can be on the same table and speak to these doctors and say, look, these are my concerns and this is why we need to do better for patients like me, it is so empowering to think what can we do as an organization to help every patient around me also find their voice, also advocate for better care, also stand up and say, listen, as a medical professional, you need to do better by me. But also as family and as a community, you all need to get your act together and stop treating me like, I'm stigmatized just because I have a bowel disease. So that I think is where the power of SIA lies, that we bring our patients and our clinicians together. And I'm really grateful to Tina for having found me and brought me into this space. But I'm also really excited to see all that's going to change through the efforts that SIA makes in the next few years as well.
It really is awesome. And it's so obvious that you're incredibly passionate about this and doing such amazing work. Since you're doing the patient side of this and your focus is really on patient outreach and advocacy, you guys have done a lot of educational pieces and about, I think every other month or so, you're doing a webinar. What's been the response that you've gotten from folks? What's been surprising in the response that you've gotten from folks?
So yes, the last, I think, 2 years, maybe we've had a lot of patient education webinars. I think what is different about the way we do it is that we bring our patient experts to speak on these panels along with clinicians. So this isn't clinicians delivering talks to patients and telling patients, okay, so this is IBD, and and kind of preaching to the choir literally, because, well, yeah, you have the medical expertise and I value it. Like, as a patient, I value that a doctor takes the time out to break down the disease to me. But I also know that having lived with this disease 24/7, I know a lot of things about my body, and I know a lot of things about the experience that I've gone through, which may not necessarily translate into medical education very neatly. So we recognize that we need to bring our patient voices forward as well. And the response we've gotten has been enormous, because we have, within the space, there have been attempts to educate patients. There has never been an attempt to treat patients as equals in this conversation. So what we do, a couple of things that we do, is that we see that patients respond when there are other patients explaining, saying, this has been my experience, this is why you should consider, an ostomy surgery. Or if you are someone who has been recommended an ostomy, here are the ways in which this has improved my quality of life. Here are the ways in which the stigma that's attached with an ostomy is complete hogwash. And here are the ways in which we can support you, because we see you, we see what you're going through. And I think that connect has been very important. One of the things that we do is that we recognize that it's very, very hard to speak about your disease openly. And even if it is to, leave a Facebook comment with a question, because I know patients are concerned that if you comment on a Facebook Live, that somebody else is going to find out you have IBD and you worked so hard to keep this disease under wraps. You don't want to lose that anonymity just by asking a question. And I feel that shouldn't hold patients back. Just the fear of disclosure shouldn't hold anybody back from educating themselves about the disease. So what we do is that we have anonymous forms through which they can feed in questions, and then we take those questions to our panelists and we're like, okay, so here's a question that's come in. Can you guys address it? So that way we're protecting the anonymity of the patients who are asking these questions as well. And we're developing resources from these talks. So we have a couple of resources up on our website from a recent talk, for instance, on, say, higher education and IBD. And we're hoping these can be circulated among patients as well, and that it's a bite-sized piece of information that they can access without having to go through the talks all over again. So these are some of the ways in which we're developing, building out the education. I'm hoping that in the future, we can also start translating. This is something we do through the IBD Desis and Saya social media platforms, where we've translated some of the resources that we've had, made it accessible in languages like Hindi or Urdu, where patients who don't have English fluency can still learn from these resources. So I'm hoping that this is something that we can develop as we go forward. The other thing that we do, which isn't necessarily a POA initiative, it's an IBD Desis initiative, and we've kind of rolled everything together under Saya. So everything is a Saya initiative in some sense. We feature patients, we feature patient stories, and we have the option of doing it anonymously. We have the option of you sharing your story with your photo and, with your name if you'd like. And we find that the more stories that we share, the more patients find us and the more other patients want to share as well. Because this isn't just about me or about the other patient advocates who are on Saya. This is about the community, and we want to create these spaces. We want to hold these safe spaces for our community to feel empowered enough to share their stories in whatever way they feel comfortable sharing. Because I think there's a lot of power in saying, I've had enough of, all of the silence I've had. I'm done. And I'm so proud that, patients are finding IBD Desis or finding, even sharing on our Facebook group, right? Like where it's all private, where it's all protected. Even there, it takes enormous courage to say, here's my story and I'm going to talk about it. We're so proud that IBD Desis holds that space for patients. And we're so proud that our talks have been able to feature patients across the world, from India, the Middle East, the UK, the US. We've covered the entire global South Asian diaspora at this point. And we're so glad we can hold that space and say, we see the power in your story. We want to hear your story. And we think that you are going to bring the change. So that's really what drives a lot of our education initiatives within Saya and through IBD Desis as well. And I'm really hoping that in the coming years, this is something we can keep plugging away at and keep developing better and more accessible resources as we go forward.
I love that so much. And that you're reaching so many people, but also that you're making the patient voice equal with the physician voice. I say all the time, my body did not read your medical textbook. Like, my body doesn't know what your medical textbook says it's supposed to do with Crohn's disease. It just does whatever it does with Crohn's disease. And I'm the expert in that, right? You're the expert in what your body does with Crohn's disease. And so I love that you're putting that patient voice right up there with the physician voice. But I have some bad news. We are at time. I could sit here and listen to you talk for another 5 hours at least, but then it would be like 3:00 in the morning or something. So
yeah.
First of all, I will acknowledge that you have given so many nuggets throughout the course of our conversation, but I'm going to ask you to narrow it down to one. So what is the one piece of advice that you want to leave the IBD community with today?
Okay, so this is something that I've had to teach myself as well. And this is something that I will say to South Asian IBD patients, but also IBD patients in general, because I think we get enough nonsense as it is from the disease. We really don't need any more rubbish. And I genuinely believe that no matter what anybody tells you, no matter what anybody makes you believe, an IBD diagnosis is not your fault. You've not done anything to deserve IBD. Needing medication is not your failure as a patient. Needing surgery is not your failure as a patient. It is just the failure of medical therapies to keep up with all of the things that our bodies throw at us. And it's fine. Having IBD has not slowed me down in any way. Having IBD has made me make changes to my life, but I'm the better for it, I feel. So why should we feel stigmatized, or why should we feel shameful of having IBD or needing medications or surgery? It's not our fault. It's just something we live with, and we just live with it for the rest of our lives as well.
Yes. And we live with it. We don't suffer from it, right?
We don't suffer from it. We live with it.
That's a very good point. I'm glad you made that distinction, Robin, because there's so many times where people say like suffering from, or that language around this, and that's not the way it needs to be couched. Madhura, what an absolute joy to listen to you and to hear your story and to talk to you. Like, seriously, I'm with Robin. Like, I have more questions for you, but we cannot keep you from your day any longer. So thank you so very much for joining us and taking the time to talk to us. Seriously, such a pleasure to listen to you. Thank you also to everybody else for joining us for this podcast. So we're going to end by saying cheers.
Cheers to you guys. Thank you so much for having me. Hi, this is Madhura. If you enjoyed this episode of Bowel Moments, please rate, review, subscribe, and share with a friend.